Hello friends. In this video, we'll discuss about the radiology recall questions that appeared in the recently concluded March 2023 NEETPG examination. We had a good number of questions on radiology with a lot of integration with other subjects. Let's look at the topics asked and the approach to these questions. Let's look at the first question. A 60-year-old alcoholic patient with history of trauma 3 weeks ago with confusion and disorientation. He is on treatment for alcohol dependence and his CT scan reveals the following finding. What is the likely diagnosis? So, a CT scan image is given and this is an elderly alcoholic patient with a history of trauma 3 weeks ago. And the CT scan is showing a hyperdense collection on the left frontotemporal region. And if you see this collection is seen crossing the sutures. You know, the frontotemporal suture is crossed. So, it is crossing the sutures, but it is not crossing the midline. So, a collection which is crossing sutures and not crossing midline, crosses sutures but does not cross midline. This is your subdural hematoma, does not cross midline. So, the answer for this question is a subdural hematoma. Being a venous bleed, it is rupture of bridging veins that cause it. So, it can occur in a chronic old trauma. So, a trauma 3 weeks back, right, and a trivial trauma, it's a bridging veins that is ruptured. So, a chronic old trauma can lead to this subdural hematoma. How to identify on the image? You will see a hyperdense collection crossing the sutures, not crossing the midline. And let us look at how the different bleeds appear on the CT scan. What do you think is this? So, this was the image that was given. This is a left subdural hematoma which is crossing the frontotemporal suture here. And this one is not crossing the sutures. It is biconvex and not crossing the sutures. What do you think is this? This is an epidural hematoma. So, this is the left epidural hematoma. Epidural hematomas are biconvex, they are lentiform, and the important point is it does not cross suture, sutures, right? So, that is how we differentiate a subdural hematoma from a epidural hematoma. And what do you think is this here? This is crescentric, crosses sutures, right? You can see the frontotemporal suture is crossed, but it is not crossing midline. So, this is again your subdural hematoma. And what do you think is this? This is a hyperdense collection which is crossing the midline. So, if it is crossing the midline but not crossing the sutures, but crossing the midline, this is your epidural hematoma. And where do you see such hyperdense sulcal spaces, sylvian fissure, basal cisterns, if they are hyperdense like that? This is your subarachnoid hemorrhage. So, keep this in your mind. So, be clear on these images. And what do you think is this, guys? So, here also you can see a crescentric collection, a concavo-convex collection which is crossing sutures and not crossing the midline. So, this is again a subdural hematoma. And why do I get these two different colors? One is more white and one is black. What does this indicate? Remember, acute bleeds are hyperdense. Acute bleed is hyperdense. And a chronic bleed is hypodense. A chronic bleed appears slightly darker. It is hypodense on CT. So, here we have two collections, right? One is hypodense and one is hyperdense. So, this is acute on chronic, right subdural hematoma, right? So, be familiar with these images. Moving on to the next question. A 32-year-old female delivered a baby at 22 weeks of gestation. The child has hepatosplenomegaly and jaundice. On CT, periventricular calcifications are noted. What is the most likely diagnosis? Remember, when the CT scan shows periventricular calcification, this is suggestive of cytomegalovirus. Imagine this is the brain and these are the ventricles. And if you see periventricular calcifications like this, such periventricular calcification, this is suggestive of cytomegalovirus infection. Some periventricular calcification is CMV. Do not confuse this with subependymal calcifications. The calcifications that are along the floor of the ventricles in a candle ripplings, these are called as subependymal calcification. And where do you see such subependymal calcifications, guys? Subependymal calcifications in the form of candle ripplings on the floor of the ventricle, on the ventricular side. These are suggestive of tuberous sclerosis. tuberous sclerosis. And where do you see a diffuse nodular calcification, especially in the region of the basal ganglia? A diffuse nodular calcifications at basal ganglia, especially at basal ganglia region. This is suggestive of toxoplasmosis. So, diffuse nodular calcifications is feature of toxoplasmosis. And if we have multiple scattered starry sky-like calcifications, these are features of neurocysticercosis. So, these are some important calcifications that are repeatedly asked, and this is seen in a calcified nodular stage. Calcific nodular stage of neurocysticercosis shows you starry sky calcifications in neurocysticercosis. So, once again, periventricular calcification, cytomegalovirus. Subependymal calcifications is tuberous sclerosis. Diffuse nodular calcification, especially in the region of the basal ganglia, is toxoplasmosis. Starry sky appearance is feature of neurocysticercosis. Which stage? Calcific nodular stage. Let's move on to the next one. A 35-year-old patient presents with fever and altered sensorium. CT scan shows temporal hemorrhages. So, there is a patient with fever and altered sensorium. The CT scan shows involvement of the temporal lobes. What is the likely diagnosis? Remember, the most common lobe involved in herpes simplex encephalitis is your temporal lobe. Most commonly involves the temporal lobes. Japanese encephalitis involves bilateral thalami. Varicella encephalitis, it involves the cerebellar hemispheres. And tuberculosis, this shows basal exudates, infarcts, and hydrocephalus, especially in TB meningitis, you see this triad of basal exudates, infarcts, and hydrocephalus. So, please remember, temporal lobe involvement is common with herpes simplex encephalitis. Next, again a repeat question. A 25-year-old male with dull aching pain in the right loin for the past few months. Urine examination reveals sterile pyuria. So, there is a patient who is coming with loin pain and sterile pyuria. So, there is a patient with a right loin pain and sterile pyuria. What is the likely diagnosis based on the given radiograph? So, the given radiograph shows a area of the kidney which shows calcifications in the parenchyma. Lobulated calcifications are there in the parenchyma of the kidney. This is suggestive of a putty kidney. So, remember a ground glass calcification and a cement kidney, right? So, these are features of tuberculosis of the kidney. So, renal tuberculosis will have this finding. A sterile pyuria should also make you strongly suspicious of renal tuberculosis. So, please remember what are the findings that we see in renal TB. In renal TB, you have some findings in the kidney, you have some findings in the ureter, and you have some findings in the bladder. In the kidney, you see the earliest findings that you see in the kidney are the moth-eaten calyces. Earliest are moth-eaten calyces. You also see ground glass calcifications called as putty kidney, and then you see dense calcifications called as cement kidney. Right. So, these are all seen in renal tuberculosis. In the ureter, you see corkscrew appearance of the ureter or a beaded appearance or tortuous appearance. You see a kinking of ureter called as kirking. You will have sharp bends or acute bends called as kirking. And on cystoscopy, you see what is called as Goldfold ureteric orifice. Goldfold ureteric orifice. Goldfold ureteric orifice. So, these are the findings in the ureter. Coming to the bladder, you see a low volume shrunken non-calcific bladder that is called as a thimble bladder. Thimble bladder. Please remember, thimble bladder is low volume shrunken atrophic non-calcific. Calcification of the bladder wall is feature of schistosomiasis, not tuberculosis. The thimble bladder is not a feature of TB. Remember, thimble bladder is a non-calcific bladder. The calcification of the wall of the bladder occurs in schistosomiasis, whereas thimble bladder that occurs in tuberculosis is a non-calcific bladder. The kidney gets calcified. You get putty kidney, cement kidney. The kidney gets calcified in TB. but thimble bladder, which is seen in TB, is a low volume non-calcific bladder. Now let us look at the other options that were mentioned. Look at this image. What do you think is this? What is this showing you? Here you can see that both the psoas muscles, they show these amorphous calcifications more on the right side, right? So the right psoas muscle is having this larger calcification, and there is also some destruction of the vertebral bodies. So the vertebral disc and the disc space is reduced with the destruction of the vertebral bodies. Along with this amorphous calcification in the psoas muscles, this is calcified psoas abscess. These are your calcified psoas abscess, right? And if you see calcifications which are extending into the pelvic calcial system like this, right, taking the shape of the pelvic calcial system, this is a staghorn calculi. This is a staghorn calculi. And nephrocalcinosis, that is calcification in the parenchyma of the kidney, nephrocalcinosis, this can be either a medullary nephrocalcinosis, which is usually medullary nephrocalcinosis, can also be cortical nephrocalcinosis. But you will have history of either hyperparathyroidism, right? You have either hypervitaminosis that is mentioned, hypervitaminosis D, or you may have this with associated with medullary sponge kidney, medullary sponge kidney. And cortical nephrocalcinosis is a feature of Alport syndrome, or you can also see this with cortical necrosis. Renal cortical necrosis can also show you this cortical nephrocalcinosis. So based on the history, right, they had given you in the question, they had mentioned loin pain, sterile pyuria, and the image showed this calcified kidney. This is a putty kidney. Moving on to the next one, a 22-year-old female presented with the swelling in the forearm. Radiograph is given below. What is the diagnosis? So on the radiograph, you can see here there is a very expansile lytic lesion that is seen in the distal end of the ulna. It is having a subarticular involvement. It is having a epiphyseal involvement, and you can see that the growth plates are fused. You can see the radius is, the growth plates are completely fused. So this is a mature skeleton. This is a mature skeleton. The growth plates appear fused. The lesion is in the epiphysis, extending into the metaphysis. It is epiphyseal lesion. It is subarticular, just under the joint area, subarticular, right, can involve the joint cartilage, and shows soap bubble lytic appearance. All of this classically favor what? GCT, giant cell tumor, or osteoclastoma, giant cell tumor or osteoclastoma. And please remember, the treatment is extended curettage with bone grafting. Right. So this is something that everybody of you should know, how a GCT or osteoclastoma appears, right? GCT or osteoclastoma will occur in more than 20 years. Mature skeletal means more than 20 years. Epiphyseal lesion, epiphyseometaphyseal, subarticular, right, shows this multiloculated soap bubble like areas with the cortical expansion that can be seen. Treatment will be extended curettage with bone grafting. So please remember, what are the important findings about GCT or osteoclastoma? It is a benign locally aggressive lesion. The most common site is the lower end of the femur, but also the most common bone tumor at the distal end of radius is also GCT. So remember these two common sites. Most common site at the lower end of the femur is the most common site of GCT is the lower end of femur. The most common bone tumor in the distal radius is also GCT. It is epiphyseometaphyseal, subarticular, can involve the joint cartilage. It develops after skeletal maturity, that is in a patient more than 20 years, shows eggshell cracklings. X-ray shows classic soap bubble appearance, and treatment will be extended curettage with bone grafting. So this is all the important points everybody should know about GCT. Now, it is important to differentiate GCT from aneurysmal bone cyst and your chondroblastoma. Remember, GCT, this is usually seen in mature skeleton, that is after fusion of the growth plates, that is fused growth plates, that occurs in age group more than 20 years, right? So more than 20 years usually. And this is epiphyseal lesion. Aneurysmal bone cyst is occurring in immature skeleton. That means you will have unfused growth plate. And age usually will be less than 20 years. Aneurysmal bone cyst is a metaphyseal lesion. GCT is an epiphyseal lesion and aneurysmal bone cyst is metaphyseal lesion. And what about chondroblastoma? What are the points that you need to remember about chondroblastoma? Chondroblastoma is also epiphyseal lesion, same as GCT. But this occurs in immature skeleton. Epiphyseal lesion in a mature skeleton is GCT. Epiphyseal lesion in an immature skeleton, right, is generally chondroblastoma. So, age will be usually less than 20 years. And chondroblastoma, the most common site of chondroblastoma is upper end of humerus, Whereas, the most common site of GCT is lower end of femur, right. So, remember these important differences. Moving on to the next one. A young male presents with low backache, morning stiffness, reduced chest expansion and redness of the eye. What is the diagnosis based on the given history and radiograph? So, you are being given a young male with backache, right, morning stiffness and uveitis features, reduced chest expansion. All of these suggest of an inflammatory arthritis, that is ankylosing spondylitis, and the radiograph that was given showed you the bamboo spine. Okay, so the calcification of the periphery of the intervertebral disc giving that bamboo spine appearance or the trolley track or tram track appearance. So, this was ankylosing spondylitis. You can see some sclerosis of the sacroiliac joint also. So, suggestive of sacroiliitis. This is ankylosing spondylitis. So, what are the findings that you see in ankylosing spondylitis? You will see there is calcification of the anterior longitudinal ligament, there is calcification of the periphery of the intervertebral disc, right. So, there is calcified anterior longitudinal ligament, calcification of intervertebral disc. You have calcification occurring of the intervertebral disc giving rise to the bamboo spine. There is calcification of the interspinous ligament giving rise to the dagger sign, and this together will form the tram track or the trolley track sign. So, tram track or the trolley track sign. And on MRI, you will see these lesions in the anterior part of the intervertebral disc. So, these lesions in the disc, these are called as Anderson lesions. All of these are features of ankylosing spondylitis. So, please remember the important findings about ankylosing spondylitis. You have sacroiliitis, you have syndesmophytes, enthesitis, inflammation around the tendinous insertion sites. There are Romanas lesions, shiny corner sign, squaring of vertebra, bamboo spine, trolley track and tram track sign, calcification of the interspinous ligament called as dagger sign. Anderson lesions are the lesions that you see in the anterior part of the intervertebral disc, and there is also osteopenia that you see with ankylosing spondylitis. So, please remember these important radiological signs associated with ankylosing spondylitis. The next question, a 50-year-old female has to undergo radiotherapy for treatment of CS cervix. Which of the following statement is true regarding ionizing radiation? Remember, normal cell and cancer cells are equally radiosensitive? No. Remember, the more mitotically active cells, they are radiosensitive. So, the cancer cells are more radiosensitive, right, compared to normal cells. So, mitotically active cells, right, rapidly dividing cells, they are more radiosensitive. GI mucosa is radioresistant tissue? No, right. So, this is a false statement. This is also a false statement. GI mucosa is not radioresistant. Bone marrow and GI mucosa, these are rapidly dividing areas and these are radiosensitive tissue. The radiation at a point is inversely proportional to the square of the distance from the source. Yes, this is a true statement. And the inverse square law says that the intensity of radiation is inversely proportional to square of distance, right. And that is the reason brachytherapy is very effective, right, because you are keeping the radiation source close to the tumor. So, intensity of radiation is inversely proportional to square of distance. This is your inverse square law and that is a true statement. So, this is the true statement and he asked you to identify the true statement. Endothelial lining of the blood vessel is resistant tissue? No, the endothelial lining of the blood vessels is a radiosensitive tissue. It's a radiosensitive tissue. Right, we use radiotherapy to treat AV malformations, right. So, to damage the endothelial lining of the blood vessels in AV malformation and to make the AV malformational non-functional, we use radiotherapy. So, endothelial lining is a radiosensitive tissue. The next question, a 51-year-old man with history of smoking presented with pain in the right arm and ptosis. Chest radiograph is given. What is the likely diagnosis? So, if you look at the chest radiograph carefully, you can see right upper lobe opacification. And if you look at the clinical history, he is a smoker, right? And he is having pain in the right arm and ptosis, telling you there is involvement of the brachial plexus and the sympathetic trunk. So, this is an apical lung cancer which is causing invasion into the sympathetic trunk and the brachial plexus. This is a Pancoast tumor, right? So, that was the Pancoast tumor given. Let's look at the next one here. A CT scan of a 50-year-old patient is given who is presenting with right upper abdominal pain. Which of the following statement is correct? So, a contrast CT study is given and you can see there is this lesion in the liver which shows floating membrane or a water lily sign. So, this floating membrane and water lily sign, this is suggestive of hydatid. So, a cystic lesion in the liver which is showing this floating membrane or water lily sign, this is hydatid cyst and the etiology is echinococcus, right? Next one. A 3-year-old child presented with fever and biphasic stridor. There is history of prior upper respiratory tract infection. What is the diagnosis based on the radiograph given? And the radiograph shows there is this narrowing of the upper part of the trachea. So, because of the mucosal thickening in acute laryngotracheobronchitis, there will be mucosal thickening causing narrowing of the lumen of the trachea in the upper part. This forms the steeple sign. So, what was given to you was a steeple sign. And we all know steeple sign is due to acute laryngotracheobronchitis. So, it is acute laryngotracheobronchitis caused by parainfluenza virus. So, this is parainfluenza that is causing this acute laryngotracheobronchitis. And do remember, on the lateral cervical radiograph, if you are given the mucosal thickening in the region of the epiglottis, that is your thumb sign, suggestive of acute epiglottitis, and the mucosal thickening causing narrowing of the tracheal lumen, this is steeple sign, feature of croup or acute laryngotracheobronchitis. Now, the next one, a patient presents with cough and fever for the last 10 days. On auscultation, there are crepes on the right side. Chest radiograph done is given below. What is the likely diagnosis? So, a patient with cough and fever with crepes and the radiograph is given, and what is the diagnosis? Is it apical segment of lower lobe consolidation, posterior segment of lower lobe consolidation, middle lobe consolidation or loculated pleural effusion? So, what you see here is there is silhouetting of the right heart border. So, when you see silhouetting or obscuration of right heart border, this is suggestive of right middle lobe pathology. Silhouetting of the hemidiaphragm is suggestive of right lower lobe pathology, right hemidiaphragm, right lower lobe, and right heart border is right middle lobe pathology. So, the hemidiaphragm is clearly seen, but the right heart border is not seen. So, this is the middle lobe consolidation. So, this is the silhouette sign. Silhouetting of the right heart border occurs due to right middle lobe pathology. And if I see a silhouetting of the left heart border, please remember, if you have a opacity which is causing silhouetting of left heart border, it is lingular pathology. It is the lingular segment of the left upper lobe, the lingular pathology that would cause the silhouetting of the left heart border. The next one, a 35-year-old patient presented with non-axial proptosis of the right eye. He gives a history of RTA 2 years back. The imaging reveals homogeneous lesion in the frontal sinus. What is the likely diagnosis? So, you have a patient with proptosis who is having a history of trauma, and the imaging reveals a homogeneous lesion in the frontal sinus, and this is causing the expansion of the surrounding walls and proptosis of the right eye. So, this is a frontal mucocele that can develop after trauma, right. So, frontal mucocele is the best answer here based on the given history, the proptosis being mentioned, RTA and homogeneous lesion in the frontal sinus, right. This would be frontal mucocele. Orbital pseudotumor would cause a diffuse enlargement of the extraocular muscle. A diffuse enlargement of the extraocular muscle would be seen in an orbital pseudotumor. Whereas juvenile nasopharyngeal angiofibroma, this would show what is called as an antral sign or a Hallman-Miller sign, right? Hallman-Miller sign. Meningioma would not be in the frontal sinus, right? So, it is clearly mentioned there is a lesion in the frontal sinus. it would be a more dural based lesion, right? So that would be different. So this is mostly frontal mucocele. Encaphalocele is usually a congenital problem, right? And expansion of the orbital walls, right? The proptosis, trauma history, all go in favor of mucocele. So you can see here, there is a right eye proptosis and you have a homogeneous lesion, right, in the frontal sinus, which is causing the orbital proptosis. This is frontal mucocele, A 60-year-old hypertensive patient presented with acute onset chest pain radiating to the neck and interscapular region. His blood pressure in the right arm is 100/60 and left arm is 170/90. Chest radiograph shows mediastinal widening. What is the diagnosis? So a hypertensive patient with chest pain radiating to the back, right? So in the interscapular region. And there is a differential pressures in the upper limb and lower limbs. So this all indicate this is aortic dissection, and the radiograph showing mediastinal widening also supports this, right? So chest radiograph showing mediastinal widening, this also supports acute aortic dissection. Please remember, the investigation of choice for acute aortic dissection in a stable patient should be CT angio, and in an unstable patient it will be transesophageal echocardiography. So this is acute aortic dissection. It is not esophageal rupture because you may see mediastinal widening, but you would not see these differential pressures in the right upper limb and the left upper limb. And the chest pain radiating to the back in a hypertensive patient with this differential pressure all actually go in favor of aortic dissection. And remember, investigation of choice in a stable patient is CT angio, and an unstable patient is transesophageal echocardiography. The next question, of 28-year-old female on treatment for infertility. So there is a female with infertility treatment, develops severe abdominal pain, nausea and vomiting. Ultrasound reveals the following appearance. What is the likely diagnosis? So a female on infertility treatment, she's developing bilaterally enlarged ovaries with large cysts, right? Multiple large cysts. And if you look at the stroma is thin. There is a central spoke wheel like stroma. The stroma is not thickened, the stroma is spoke wheel stroma. So this goes in favor of ovarian hyperstimulation syndrome. Remember, whenever HCG levels are elevated, is it endogenous increase in HCG or exogenous increase in HCG? Exogenous will occur as a part of infertility treatment, right? We give injections of HCG, and when you see bilaterally enlarged ovaries with cyst, you call it a ovarian hyperstimulation syndrome. You may see associated third space collections, pleural effusions, right? Ascites, there will be hemoconcentration and death also sometimes. All of this, third space collection, pleural effusion, ascites, pericardial effusions, right? All of these in a female who is receiving injections of HCG for infertility, this should be ovarian hyperstimulation syndrome. But if you have endogenously elevated HCG, as in, molar pregnancy or in multiple gestations, multiple pregnancies, this should make you think of theca lutein cyst. So because the history gives you infertility treatment, the better answer is ovarian hyperstimulation syndrome. In polycystic ovarian syndrome, the important finding that you see is a large central stroma. So you have a large central stroma, thick central stroma, which makes the ovarian volume more than 10 ml. And you have small cysts in the periphery, small peripheral cysts. And the cysts are also more than 20, right? So this is PCOS. The important finding in PCOS is a thick central echogenic stroma. A spoke wheel like stroma, this is OHSS, central spoke wheel like stroma, right? With large cysts, not small cysts. That is OHSS, right? So that is how we differentiate on the imaging also, which is PCOS and which is OHSS, right? Now, look at the next question here. A radiograph of a patient who has knee pain for the last 3 months is given. There is no history of trauma. What is a correct statement regarding the diagnosis and management of this condition? Is it a fracture of the upper pole of the patella, which requires a cast placement, a cylindrical cast, avulsion fracture of patella requiring a tension band wiring, a bipartite patella, do radiograph of the another knee, avulsion fracture of the patella where interfragmentary screw fixation should be done. Please remember, you are seeing a triangular defect in the superior lateral aspect of the patella. So, if you are seeing this location on the superior lateral aspect of the patella, this goes in favor of bipartite patella. You have a sclerotic margin and the location is most important, the superior lateral aspect of the patella. This should favor bipartite patella. And bipartite patella in 40 to 50% of the cases can be bilateral. So, you would want to do a radiograph of the other knee, right. So, that would help you diagnose whom the location is important, superior lateral aspect of the patella. Avulsion fracture of the patella, you will go for tension wire binding. But bipartite patella, it's a more congenital problem. You need to just look at the other radiograph to understand whether the other knee is also involved or not. A 15-year-old female presents with shortening of the limb, multiple swellings in the limb and multiple skin lesions. So, there is a limb shortening, there is multiple skin lesions. X-ray pelvis is shown below. What is the likely diagnosis? So, the X-ray pelvis shows a classic deformity of the femur called as Shepherd-Crook deformity. Shepherd-Crook deformity. And Shepherd-Crook deformity is feature of a fibrous dysplasia. So, remember F for F like this. So, fibrous dysplasia will have Shepherd-Crook deformity. Ground glass opacities in the bone, they will have ground glassing in the bone with Shepherd-Crook deformities. And remember, this patient is a female, precocious puberty in female, precocious puberty or endocrine problems in the female with Caffi-Oley spots and multiple bone polyostotic fibrous dysplasia. Polyostotic fibrous dysplasia, all of these go in favor of McCune-Albright syndrome. McCune-Albright syndrome. So, multiple endocrinopathies, precocious puberty in a female with Caffi-Oley spots and polyostotic fibrous dysplasia. This is suggestive of a McCune-Albright syndrome. The image given was a Shepherd-Crook deformity. Shepherd-Crook deformity is seen in fibrous dysplasia. And another skull radiograph was given in a child with 2-month history showing this calcified lesion on the parietal bone. So, on the right parietal bone, you can see here there is a right parietal bone. You see a calcified lesion which is not crossing sutures. So, this is a calcified cephalhematoma. This does not cross suture, right. So, this is calcified cephalhematoma and this is a subperiosteal hematoma that gets calcified, right. So, and it does not cross sutures. That is how we identify this cephalhematoma, a calcified cephalhematoma. So, these were some important questions that came up in the exam and I hope you have done most of them correctly and you have good results also. All the best.